Thank you very much indeed for inviting me to talk to you about this very important subject and very common. And I'm sure you see quite a lot of patients with abnormal patterns of bleeding in and around the menopause. I just wanted to agree with you on some definitions. We are talking today on perimenopausal bleeding, not premenopausal, perimenopausal bleeding. And the perimenopause, these are the years leading up to the menopause. And if you look at the literature, this phase can actually last up to 10 years. So there is a wide spectrum of variations and deviations of patterns of bleeding happen during that time, and the majority, obviously, of these patients will come to you in primary care. The essential change behind the fluctuations in periods in that time is changes in the ratios between estrogen and progesterone. It is as simple as that in the physiological sense. So what changes we would expect in the menstrual cycle during the perimenopause? Irregular bleeding is very common, spotting, longer and heavier periods, shorter and lighter periods. The number of days between the periods increase or decrease, and as a woman approaches the menopause, a lot of women have either infrequent periods or they can get a pattern of 2 or 3 heavy periods and the periods stop. But what I'm trying to allude to is before that, there are changes happening within the estrogen-progesterone cyclical variation. And of course, some women can skip periods. Abnormal perimenopausal bleeding, and these are the women who are going to come to you, and their patterns have changed completely. They have very heavy bleeding, bleeding that lasts longer than normal, bleeding that occurs more often than every 3 weeks, and bleeding that occurs after sex or between periods. So if we are to look into the causes of abnormal perimenopausal bleeding, hormone imbalance, and in that respect, don't disregard women coming up with abnormal bleeding patterns. It's always valuable to do their FSH and estradiol levels, because that will give you an idea where they are heading. But with that, and I'm going to talk to you a little bit later, if you combine that with ultrasonography, then you will get a more objective assessment of the pattern of bleeding and whether you should refer or not refer, but the majority of these cases can be treated safely in primary care. Fibroids is an interesting problem. The treatment of fibroids, most fibroids are asymptomatic. The fibroids that would cause abnormal bleeding are usually submucous fibroids or fibroid polyps. And they can present with intermenstrual bleeding, or they can cause heavy periods or abnormally heavy periods. But some types of intramural fibroids and subserous fibroids, if they are contained and normally they don't cause any symptoms at all. Often we are asked, okay, when should we refer these patients with fibroids? And there's a lot of controversy. But my view is that if you are able to, if the uterus is palpable, the woman is uncomfortable and is causing symptoms such as bladder symptoms, and it's obvious, then the treatment nowadays is much simpler. And I will talk a bit later on new and current innovations in hysterectomy techniques. Cervical polyps, they cause postcoital bleeding, but the majority of cervical polyps are totally asymptomatic, and they are discovered at routine smear tests. When we talk about cervical polyps, make a clear distinction, and I'm making a clear distinction between small sessile polyps, and these are very common, and the glandular, larger polyps, which the stalk of which can be coming from the cervical canal or can be coming higher from the uterine cavity, and these are really need to be referred and removed quickly to exclude endocervical carcinoma. Endometrial polyps, and they will present with different patterns of bleeding and intermenstrual bleeding, and contraceptives. Women are taking, who are on Mirenas, women who are taking progesterone type preparations, they often present with irregular patterns of bleeding. But don't forget other causes such as thyroid problems. Hypothyroidism causes menorrhagia. Thyrotoxicosis and the hypothyroids can cause actually amenorrhea as well. Clotting problems, and don't forget pregnancy. Sometimes women at the ages of 44, 45 presenting with an abnormal pattern of bleeding, we tend sometimes to forget that a pregnancy may have happened, they may have had a missed abortion, and the abnormal bleeding pattern is related to a pregnancy. Polycystic ovary syndrome, that will cause fluctuations in estrogen level, and I'm sure Leila will be talking about that as well. But one component of polycystic ovary syndrome that should not be ignored, and just keep it in mind, is high estradiol levels in an overweight woman, because these type of women will have a higher risk of endometrial hyperplasia and endometrial cancer, and I'll mention some of the risk factors associated with endometrial cancer. Cancer of the endometrium presents itself in an abnormal pattern of bleeding that's usually prolonged, and if it has been ignored or undiagnosed, you find that it has a smell to it sometimes. Hormonal imbalance may cause an absence of periods, amenorrhea, but chronic failure to ovulate, and this is where the group of polycystic ovary syndrome women can come into it, can result in hyperplasia or endometrial hyperplasia, which is a risk factor for endometrial cancer. We talked a bit about fibroids, but a lot of people ask me, if a woman is completely asymptomatic, with fibroids, should we do anything at all about it? And here where the controversy lies, because in a small proportion of women with fibroids, large fibroids, and if they present you with slight pain, don't ignore it, because you will get the occasional woman who has cancer of, within her fibroids. And as I said earlier, most cervical polyps are benign and asymptomatic, and they can cause postcoital bleeding. Oral contraceptives is a minefield on their own, and as Sally mentioned earlier, obviously, if you are addressing the discrepancy between estrogen and progesterone, often that will lead to a normal pattern of periods without any intramenstrual bleeding. But some of the newer preparations, progesterone medications, can be associated with irregular pattern of bleeding. And just remember, although a lot of us don't put the older coils, I'm sure you do, the copper coils, but they are associated in some women with heavy periods. Remember the thyroid problems? Clotting problems should also be thought of in someone you can't find a probable cause for the abnormal pattern of bleeding in the perimenopause. Always think of pregnancy, as I said earlier. Polycystic ovary syndrome, I'm not going to elaborate a lot on it, but I want to remind you that there are different types of polycystic ovary syndrome patients. There are different types of hormone profiles. There are different ratios between the FSH and estradiol. But please do pick up the classical woman who has amenorrhea for a period of time, and her estrogen is high, she's a bit overweight, suddenly she presents to your clinic with a very heavy flow. These type of patients do their estradiol levels. If they are high, do a scan, because the scan will pick up endometrial thickening. And I'm not talking here about the endometriums that are 5 millimeter, 10 millimeter. These endometriums are 15 millimeters, 20 millimeters, and they should be addressed. They should have hysteroscopy and endometrial biopsy. Cancer of the cervix, thank God we don't see a lot of cancer of cervix, but in that respect, and I'm talking as someone who actually started the first colposcopy clinic in Farnborough in 1986, so have a bit of respect for me. I just want to make one point, is that most of the cancers we see are of the ectocervix, squamous epithelium. The difficult cancers that we are really sometimes a puzzle, and sometimes we are not very good at diagnosing early, are endocervical columnar epithelium cancers, because they don't behave, they don't present in the same way as ectocervical squamous epithelium cancers. Risk factors of endometrial cancer include advancing age, early menarche and late menopause, women who've never had children, irregular pattern of periods, history of infertility. History of infertility, someone who's been taking medication, Clomid, gonadotropins, over a long period of time, they've never become pregnant, are included in the high risk factors. Other risk factors, medications containing obviously high doses of estrogens or unopposed estrogens. If you read the recent Royal College guidelines, which have been published 3 months ago, obesity is a major factor in carcinoma of the endometrium. Treatment with tamoxifen is interesting because a lot of these women are at a higher risk of developing endometrial polyps. With endometrial polypoid formation, you can get endometrial changes as well. And certain types of ovarian tumors, diabetes, raised blood pressure, gallbladder, thyroid disease, obviously family history of ovarian cancer or colon cancer, and I've also added smoking, which has been mentioned recently. In terms of the investigations, just go through the process of physical examination to pick up abdominal, pelvic abdominal masses and large fibroids. Blood tests, appropriate blood tests, FSH, estradiol, thyroid function studies, or clotting screens. Ultrasound is pivotal. And when you're interpreting ultrasound, the preference is a transvaginal ultrasound scan. It's much more accurate than an abdominal scan. But of course, in some women, they can't have transvaginal sonography, so you have to rely on the abdominal. But the findings, I don't want to be critical, but some of them are not as accurate as they should be, and they should be performed by really specialized, people who are specialized in ultrasonography. Hysteroscopy and curettage is a gold standard if there is endometrial hyperplasia or prolonged undiagnosed bleeding that you can't make. And hysteroscopy has revolutionized the whole way we look at things, because you can look at the endocervix, you can look at the endometrium. If there are polyps, you can resect them. And we have a new system which can actually suck them out, morcellate them. It's very quick. And if you have a fibroid polyp, it can be resected. So these are all what are called day case type procedures, which are very easy to perform. And then in a woman who has a fibroids, a recurrent abnormal pattern of bleeding, intramural submucous fibroids that cannot be safely resected, there's always the place for hysterectomy. And I'll talk about hysterectomy very shortly. So the management will obviously depend on the cause. And one of the treatments that are available nowadays is endometrial ablation. So in someone who has mild hyperplasia, in a woman who has completed obviously a desired family unit and who doesn't want to go for egg donation, because women can change their mind. And we have increasingly a lot of women between the ages of 44 and 48 who are now coming requesting egg donation. So we don't ignore that. Hysterectomy will depend obviously on the type and the pathology, but I'm very proud to tell you, I mean, the very first laparoscopic hysterectomy was done in 1989 at Chatsworth Park Hospital, and 2 weeks ago we did the first laparoscopic hysterectomy through a single port incision, through a 12 millimeter incision through the umbilicus. Successfully, it took 45 minutes. So read it about it on the Daily Mail tomorrow morning on Sunday. Okay, but these things, I mean, surgeons have, you know, they do it as a routine, and it's a natural progression, not of our abilities, you know, to be clear. It's refinement of instruments, and things are improving, and all of us are trying to move away from the 12 centimeter incision, the midline incision, and to improve patients' recovery. And thank you very much indeed.